get started. So what is a hernia? Basically, it's just a hole in the muscle. It's a defect in the muscle that's not supposed to be there. It allows contents of the body cavity to protrude or herniate. Herniation means something bulges out through it, but the hernia is not the bulge. The hernia is the hole. That's the actual problem. Usually contains intra-abdominal contents, so common things would be fat or bowel. Everybody has a little fat in their belly, and that's usually the first thing that'll bulge out. As they get bigger, intestine can bulge out through there too, which that makes them larger. They tend to become more symptomatic if that happens too, and there's some other complications which we'll talk about. But any organ can herniate. If you've got a big enough opening, you can have liver bulge out, stomach can bulge out. Hernias, you can get hernias around towards the back and even in the diaphragm, and kidneys can bulge through those. So if it gets big enough, anything can, but most commonly it's going to be fat or some intestine. They may be congenital or acquired. Congenital means you're born with it. You may know or had it yourself. Children often are born with the common ones are going to be a belly button hernia, an umbilical hernia, or an inguinal, the groin, usually in male children, because the testicles do start in the belly and they descend down as they come through. That hole's supposed to close up, but it doesn't always. Those congenital ones, particularly the belly button hernias, often will close on their own. Those don't get fixed early. The groin ones we do, but you can be born with them. Those are usually pretty obvious. And then acquired, and that's most common. As we get older, we tend to get them. And then, of course, you can do certain things or have certain jobs that you do during your lifetime can increase your risk. A lot of things, and we'll go into that in a minute. So most commonly, they're acquired. There's over 200,000 abdominal hernias, and that's all types of abdominal hernias diagnosed each year in the United States. And that's just how many are diagnosed a year. There's millions of them out there, but each year about 200,000 or so can be diagnosed. They may or may not have symptoms. Some people don't even know they have them. In this day and age, we do a lot of x-rays for other things like CAT scans and MRIs, and so a hernia will show up and tell somebody, I didn't even know I had it. So that's common. So they may or may not have symptoms, and the symptoms may change over time. As they get bigger or you do certain things, and then those may come and go. The hernias do tend to enlarge with time. We can't tell you how quickly they'll get bigger. There's a lot of factors, location, what you do, weight, all kinds of things, but they do tend to enlarge over time if you don't get them fixed. And the symptoms can change over time too. All right, hernia risk factors. Well, there's Arnold, that's one of them. I don't know if he's ever had one or not, but that'll do it. But the risk factors, previous surgery, that's the incisional hernias, obesity, chronic cough, lifting and straining, anything that increases pressure and stress on the abdominal wall has a potential to result in a hernia. Now, it's not that common for it to happen suddenly like that, although many people know somebody who was doing something and they felt a tear or a pop. Most of the people I see in the office don't feel that tear or a pop. They gradually notice a bulge or discomfort over time, and then it comes, but some people do. Ascites, that's fluid in the belly, usually from liver issues or heart failure issues. People that are on dialysis, a special type where they put fluid in the belly can get it. Smoking, pregnancy, unfortunately, pregnancy causes a lot of things. My wife says it's worth it. I can't really speak for her. I didn't have to go through it. And then family history, there are certain types of, we call them connective tissue disorders, where things are weaker. Things like collagen proteins that provide strength in the tissues can be a little weaker. It's a lot less common, but there are certain conditions that increase your risk for hernia that are inherited. What kind of symptoms do they have? Pains. Most common one that people come in complaining of, pain and a bulge, usually together. But they don't always have pain. Sometimes it's just the bulge. Sometimes there's pain for a little while, then the pain goes away, especially in those people that feel the pop or the tear. Hurts like crazy for a while because it's acute. It just happened. It tore, it gets inflamed, it hurts. And typically men will not get it checked out for a while. It'll go away. And the pain often does, and then they feel a lump there that squishes in and out, and then they end up getting seen. Swelling, of course, that's the bulge. Sometimes difficulty with bowel function, if there's bowel involvement. Even if you don't have a blockage, if you get part of the colon, there's especially in the groin hernias, part of the colon is down there, or small intestine. it comes out, it can get a little bit kinked, or things have to work harder to move through that because it has to go through a little hole in the back out, so you may start getting some constipation. Sometimes it's intermittent. Sometimes people will find if they're going to the bathroom, they can push on where they feel it, and that may help it. So, and then nausea, vomiting, that's usually if they've got a blockage, and that's usually pretty clear. And then that's what this is. Incarceration or strangulation is a term a lot of you may have heard, a strangulated hernia. That just means that it won't go back in. Whatever's bulged out is stuck. And if it's bowel that's bulged out, if it's fat, it may cause pain. It's not necessarily dangerous. If it's intestine, it can get kinked, it causes a blockage. You may start throwing up. Things get real tight, painful. It'll be red and hard at the hernia too. And then you start passing gas and have bowel movements. It's usually pretty obvious when that happens. Most people end up in the emergency room. And if we can't get it back in, we go right to surgery. Even if you can get it back in, if it's a true incarceration, we usually try to reduce it. If it does, then we set you up to fix it just as soon as possible in this scenario. So what do we do for hernias? Sometimes we just wait and see. That's not uncommon. A lot of times people do that on their own before they ever get seen. They've been waiting for years because it doesn't bother them that much, and that's okay. It really is okay. It is reasonable if it's asymptomatic or relatively asymptomatic. So if it doesn't bother you, or if it's minimally symptomatic, it's reducible, you don't really have much discomfort, and you might be higher risk for surgery. Sometimes we'll recommend just seeing what it does. If it starts causing more problems, you can revisit it. So wait and see is appropriate in some patients. They've done a lot of studies to show, kind of gone back and forth. Used to every hernia got fixed. You came with a hernia, your surgeon says get fixed. And then there's a period of time where they said, well, maybe we're fixing too many hernias, we're doing too many surgeries on people. And so there's a lot of studies that came out that where they would just watch people, what they did. And we're finding that right now we don't really know. If it's symptomatic, it's recommended that you get it fixed. Even if it's just a little symptomatic, or if you do if you have a job or whatever activities you do where you're doing a lot of lifting or straining, it's more likely to get bigger. The bigger they are, the harder it is to fix in some cases. So most recent research, basically, we don't have it far enough out to see if we can actually, by just waiting and seeing, if we're preventing people from actually getting surgery or if we're just delaying the inevitable. So if you don't get it fixed now, 10 years later, do those same people that didn't get it fixed before, do they still have to get it fixed, or do they go the rest of their life without getting it fixed? So it takes a while to get enough studies built up, and it really just, like I say, in the last couple of decades, it's been looked at. So right now, most of the literature in the surgical journals, at least, so take that with however you want to take that, recommend getting them fixed. If it's bad enough that you come in with some symptoms, get it fixed. But if it's really not causing you problems and you don't want to have surgery, or if you're higher risk, it is okay to wait. As long as you understand you might get it fixed at some point. Hernia belts or truss, for the ones on the abdominal wall, there's hernia belts, there's like back support things that just add some support and pressure, try to prevent you from having symptoms. Those are used sometimes, and then a truss, those are the belts that go down lower for the groin hernias. They have them for left, right, or both. It has a little pad that puts pressure right where the hernia is. Sometimes we'll give them to people while they're getting ready for surgery, or if they don't want to have surgery or are high risk, to see if it'll help with the symptoms. They're kind of hard to manage, and sometimes they're not always effective if you don't get it on right or things shift. So it really depends on the person. But they can be useful to help alleviate some symptoms until you want to get surgery or it's determined that you need it. And then, of course, the only way to really cure it or get rid of it is surgery. It's a hole. There's no medication that'll fix it. It's a structural defect, so you have to fix it if you want it gone. So there's 3 basic ways, and we'll go into this. But there's open, which is making an incision, going down through the hole, closing it, usually fixing it with mesh. Some of it depends on the type of hernia, but for most hernias these days, if they're big enough and in the right location, we do recommend a mesh repair. And laparoscopic, and that's just using the camera with the little incisions, kind of like gallbladders are done. Probably one of the most common things we do, gallbladders and hernias, be the most common laparoscopic surgeries that general surgeons do. And then the robotic assisted laparoscopic, and that's the robot surgery. I put robotic assisted laparoscopic because it's still camera surgery. It's laparoscopic surgery. The only difference is we're using the robot connected to those ports with the camera and the instruments on the inside, which I'll show you a little bit here, and we'll show you on the robot. Hopefully we'll see a little bit better. I think they're setting it up out there. It gives you more dexterity on the inside. You can just do more than you can with the standard microscopic instruments, and that's really, but it's still the little holes. Doesn't change that. So let's talk a little bit about my approach, and I kind of mentioned it a little bit as I've gone along, but everybody's different. Everybody has a different hernia, different abdominal wall, different tissue strength, different activity levels and everything, so it's tailored to the patient. I do all these techniques now, which I think is good, because I can offer it depending on what you need. And sometimes we'll plan on laparoscopic or robot surgery, and there's anatomy variations that we find. We may have to convert to another technique, sometimes open or whatever. So I tailor it to the patient. But our goal is to get a durable repair, so get that hernia fixed the best way possible, get you back healed and active again as quickly as possible and at the lowest risk. For some inguinal hernias, one side, small, open approach is great, and I'll often just offer that. What I find for inguinals, I usually will offer open or laparoscopic if they have one that can do either way. I'll talk to people about both ways and let you decide. Most people want a laparoscopic, but that's the option. For very small ventral incisional hernias, there are some people that have a tiny belly button hernia that may be just tender when they bump it on something, or it bothers them. If it's a centimeter, less than half an inch, those can often be closed open. You just make a little incision and you put stitches in to close it. Those don't always need mesh. Definitely when they get to about 2 centimeters, which is almost an inch, they need mesh because the recurrence rate is higher, or even smaller ones in people that are at high risk, smokers, people with obesity, that sort of thing. But sometimes we can do those open, and we'll just say we can fix this easily with still a fast recovery time with minimal pain open. Of course, general anesthesia risk, but a knees repair, sometimes there's anal ones we can do without that, so I may offer it there. The laparoscopic method, I still do that for most of my inguinal or groin hernias. I do a single site, single incision, so there's different techniques, but 3 incisions is kind of the standard laparoscopic way. I've been doing for several years just with 1 incision at the belly button, about an inch and a half long. We can put all our instruments through that one. We have a special port. You can go down. You're working in a very narrow area down in the groin. You can fix both sides through there. It's only the 1 incision, and it's actually pretty quick, so it's a short anesthesia time, and it's the same type of repair as far as putting the mesh in the same place. Everything's exactly the same as if I did it with the robot. And it's through the 1 incision, and it's quick and easy. So most of my inguinals or groin hernias that are initial groin hernia, whether it's one side or both sides, I'll do just standard laparoscopic. I don't need to worry about the special suturing and all that. It's just because of the technique. Now, for recurrent ones, for people that have had it fixed before, especially if they've had it fixed already laparoscopically, so there's scar tissue, there may be another piece of mesh, there's going to be more work to free things up and everything. You may need to do some more suturing. I'll use a robot. And that's usually 3 incisions, but it allows me to do it a lot safer and better. And then, of course, any complex hernias in the groin I may do with the robot, especially if they have a large one. If the groin hernia gets big enough, you can have your bowel down into the scrotum in men. In women, they don't get that big, but in men, they can all be down there. And those usually often just have to be done open, but with the robot, it's better. You can get everything back in easier and get it closed. But those aren't that common. That's usually somebody who's really put it off. And then I'll go right to the robotic assisted laparoscopic ones. For definitely just about all the ventral hernias that are bigger, that's where I'm going now, because I can close that defect. If I find more hernias, I can address those easier and get a better repair that way. So mostly the incisional and the bigger ones up here I'm doing robotically. Some of the groin ones